Very good afternoon. So I'm here to talk about posterior subtenon triamcinolone injection. So it's a corticosteroid delivery directly into the posterior subtenon space. It is localized and sustained drug released for mainly to reach the posterior segment tissues. It is usually preferred in patients where high dose corticosteroids are contraindicated or if there is very severe inflammation, and it can also be used for macular edema and other ocular inflammation, which is refractory to systemic therapy. The advantage, it's low cost, widely available, and it can be done as an OP procedure. Indications, we can use it for cystoid macular edema, not only inflammatory, for other non-infectious uveitis sequelae. Can be used for edema following retinal vein occlusions, diabetic macular edema, ERM, and rarely it can be used in cases of scleritis also, though we have to be pretty cautious while injecting the medicine because the eye will already be very tender. And inflammatory CNVM also we can use it. And in cases where there is severe hypotony or choroidal detachment, in order to raise the IOP, we can use PST injection. Contraindication are infectious uveitis, especially viral and toxoplasma. In TB, we usually prefer PST injection after the intensive phase of ATT and after the retinochoroidal lesions have completely resolved. If there is any residual macular edema, we can go ahead with PST. So these are examples of how just one PST injection can make a difference. This is an edema with ERM, we're resolving with one PST injection. The dosage, the usual dosage we prefer is 0.5, but up to 1 ml has also been used at concentration of 40 mg per ml. The usually used technique is the Nozick technique, where the supratemporal quadrant is used. There's just go to the video.
Things required for PST injection are 1 cc syringe, 26 gauge needle, triamcinolone acetate vial, topical anesthetic and antibiotic agent. The vial is shaken well before loading the drug. The required dosage of drug is then gently loaded. A fresh 26 gauge needle is then used for injection. After anesthetizing the eye, the patient is made to lie down in a supine position and asked to look down in the opposite direction. The needle is then gently inserted with the entry site as posterior as possible and moved in the sideways direction to ensure that the sclera is not penetrated. The eyeball should not move with the movement of the needle. Once the right plane is achieved, the drug is slowly injected.
So other modifications, we can even use the infratemporal quadrant, especially in very thysical soft globe. In order to prevent globe penetration, we can use the infratemporal quadrant. And you can sometimes even use a LIMS forceps to hold the conjunctiva so that you have better visualization of the space when you're entering. And an IV cannula made up of polytetrafluoroethylene has also been used for PST injection. Routinely after 15 days or 1 month after PST injection, intraocular pressure needs to be checked, fundus examination to rule out any globe penetration, and any congestion or tenderness at the site of injection needs to be monitored because there can be focal areas of infection following PST injection, especially when sometimes the drug is deposited in the subconjunctival space. We can see a white deposit still persistent. So that can cause even necrotizing scleritis or scleral abscess formation. Complications, the most common complication is high IOP glaucoma, seen up to 36% of cases. It can arise anywhere between 2 weeks to 5 months. And risk factors include high dose of PST, baseline high IOP, young age, myopia, patients in whom multiple injections have been given, and steroid responders. Management is usually anti-glaucoma medicines, removal of the depot, or glaucoma surgery in case of very refractory cases. Other complications include subconjunctival hemorrhage, cataract progression, scleral abscess, scleral perforation, ptosis squint, and very rarely vascular occlusion, especially sometimes if we inject the drug very fast, it can even end up in a vessel occlusion. So, conclusion, it remains a valuable cost-effective treatment in selected cases, especially when the macular thickness is not very high. And careful patient selection and technique is required to in order for a high safety profile. And it is still relevant despite newer intravitreal injections. Thank you.